Hi all, Dr. Pargament here with another installment of frequently asked questions. A common question that patients come to have answered is, what is causing my lower lid bags? The answer to that question is somewhat determined by what they perceive their bags to be. Now, some patients notice some swelling over the cheekbone and they call that the bag. Some patients have some puffiness around the lower lid and they refer to that as the bag. If the bag is the area that's swelling over the cheekbone here, frequently is due to what's called malar edema or swelling over the cheek within the soft tissue. That could be challenging, though not impossible to treat surgically, and that is usually due to some impediment in the lymphatics, which are the vessels that drain fluid off of the face or away from the face. And if your lymphatics are slightly less competent in this area, you will see an accumulation of swelling over this cheekbone. And that is oftentimes seen in patients who smoke or patients who sleep on their face, oftentimes sleep apnea patients who use the CPAP. That is different than lower eyelid bags due to puffiness directly below the lash line or within the eyelid itself. You know, the eyelid, if you push on your eyeball, it's cushioned in your eye socket. That is cushioned by normal fatty tissue. Everybody's got it. The retaining wall, called the septum, that runs in here and also runs up here, can sometimes weaken either congenitally or with time, and that allows that fatty tissue to bulge forward, and so you see a forward prominence of the puffiness, which is why if you kind of push on your eyeball, you'll see that puff get a little bit bigger. If you're not sure if the bag that you have is due to the puff or malar edema, you can push on your eyeball and see, does it make the bag bigger or is it unchanged? If it's unchanged, it's likely malar edema. If the bag gets bigger, it's often due to that fatty prolapse. That fatty prolapse type of lower lid bag is ideal for surgical intervention, where we make an incision hidden on the back of the lid and we access that puffiness. In some patients, we will transfer that into the cheek to fill in the dark circle and to remove the puff. It sort of kills two birds with one stone. Or in some patients, we will simply excise some of that puffiness as well. Frequently, when we excise that, we will then take some autologous fat harvested elsewhere and use it to help revolumize the midface. So I hope that answers the questions. Hope it didn't confuse you anymore, but it can be somewhat variable essentially, and it really requires an evaluation for us to best determine what will work for you. Hope that helps.